your classmates to join this class or session. We are about to begin. Okay, so you are supposed to have the quiz today on acid-base balance. No? Unfortunately, there was some misunderstanding. Sorry, akong may kasalanan nun. Akala ko kasi hanggang 5 o'clock ang aming CEU Consumers Co-op, no? So, akala ko hanggang 5, no pala hanggang 12. Actually, katatapos lang ngayon, nag-overtime 1 o'clock. Okay, so anyway, that's why many of you went home already, no? Maybe after reading my announcement, no, the announcement that I posted early in the morning, kaninang aga kong nag-post, no. So nakauwi na yata yung iba or hindi na umalis ng bahay yung iba because they thought that there would be asynchronous class today. I'm sorry for the miscommunication. So many through sino ba yung nag-email sa akin na requested for kung pwede online na lang. Okay? So that's why we are holding our class for the first time na online. So I hope you bear with me. Okay? So in preparation for your long exam, yung totoo ng exam ng acid-base balance on next Saturday. So I enjoined each one to watch the video. This is a very nicely made video on ABG, arterial blood gas. I understand that there were some students who failed to attend the class last Saturday because they are officers of medtech council yata may activity kayo nun. So they were excused, so I don't like that they be deprived of the learnings on ABG. So I look for a very nice, I searched the internet and I found this very nice video. Panoorin natin na sabay-sabay para at least may isasagot kayo sa exam ninyo. Okay? Maganda itong video na to. Sana marinig niyo.
And because we're dropping our oxygen, causes us to breathe too slow. Like,
nakikita niyo ba?
Let's do a comprehensive review on acid-base imbalances, starting with respiratory acidosis. This condition occurs because we have a decrease in lung ventilation. And whenever we have that, our body starts to retain CO2, carbon dioxide, which is going to drop our blood pH. Now, what are some things that can lead to...
So this is a video on ABG. And you know ABG, diba? Acid arterial blood gas. This is on acid-base balance, no? So ABG, arterial blood gas. So this is one important laboratory test, no, done in the clinical laboratory, and this includes tests such as determination of blood pH, yun ang una. Number 2, estimating the partial pressure of carbon dioxide or yung tinatawag na PCO2, partial pressure of carbon dioxide. And the third one is on the determination of the serum or plasma bicarbonate level. So yung tatlo na yan, no, they are the important components of a test collectively known as the ABG test or arterial blood gas. And in doing the test, of course, the specimen of choice is the arterial blood. So arterial blood collection is quite different from the venous blood collection, and medtechs are not allowed to collect arterial blood. No? Dapat mga medical doctors yan. Bakit? Kasi malalim ang pagtusok dyan. No? You will, the phlebotomist needs to puncture the artery, and I think everyone knows that artery is deeply seated, deeply located, malalim. So, kesa sa veins, you can see them with your eyes. Kulay green or kulay purple dyan na nakikita nyo, kitang-kita mo ang mga veins, no? Because they are superficially located. Unlike the artery na deeply located, no? They are located in the connective tissue, no? Natatabunan minsan ng muscle, so hindi mo siya nakikita sa underneath the skin. So one way to collect the blood successfully is to do the Alright, so you have to palpate, no? Kailangan hanapin mo, pulsuhan. You have to get, to locate the pulse. So, pag napulsuhan mo na, more or less, yun na yung artery, no? And usually we collect the blood from the femoral artery, yung tinatawag na fem-top, no? So, femoral artery. Alright, so ganun kinukuha yung blood sample. And then, unlike the venipuncture where we usually have certain angle, ito medyo near 90 degrees ang angle ng pagkuha ng blood sample. And it's important that there should be no bubble formation, no? And ideally, no, the blood sample has to be collected through or using glass syringe para hindi maiwasan ng diffusion ng gases, no, in the pores of plastic syringes. Also, the sample needs to be prepared, no, or needs to be taken or kailangan immediately after collection. You have to mix it with the heparin. So, kailangan heparinized blood, no? So, the recommended anticoagulant in doing the ABG test is heparin, no? So, heparin, the recommended anticoagulant. Okay, now, here we will be hearing a very comprehensive discussion on acid-base balance, okay? Now, when you say acid, no, you are referring to the carbonic acid, H2CO3. In the video, you will see that the H2CO3 or the carbonic acid is actually made from water and carbon dioxide. No? Therefore, when we speak about acid, we are referring to carbonic acid. Now, the relationship of PCO2, the carbon dioxide, with the pH, no, is inversely related. So if the pH goes down, the level of PCO2 goes up. So they are inversely related. No? So in case of respiratory acidosis, the blood pH is lower than 7.35. So pH goes down. And so we expect that the level of carbonic acid or the PCO2 would go up. Okay? So, tataas ang PCO2. So, I gave you the normal values last time. A normal value for PCO2 is 35 to 45 millimeter of mercury. So, therefore, that means that when the PCO2 level exceeds 45 millimeter of mercury, then the blood pH goes down, no? Lower than 7.35. So, the condition is known as respiratory acidosis. Okay? Now, bakit acidosis? Bakit nag-less than 7.35 ang blood pH? Bakit bumababa ang blood pH? It's because the CO2, saan ba nanggagaling ang CO2 or carbon dioxide? The carbon dioxide is a metabolite of a cell. So when the cell respires, the cells breathe also, just like us. No? So one of the products of metabolism is carbon dioxide. So the carbon dioxide, which is a metabolite of cells, this will diffuse in the blood. So it circulates and it mixes with water. It mixes with water. So carbon dioxide in the blood from the cells or tissues of the body now mixes with water. So water plus carbon dioxide equals carbonic acid. And that is H2CO3. So then, nasa lungs na ngayon yan. Now, the carbon dioxide is meant to be exhaled out of the lungs. So, mula dun sa cells, nag-respire yung cell, nag-metabolize, labas yung carbon dioxide, pupunta sa dugo, and then Doon sa dugo, mix up yan with water and then pupunta sila sa lungs. Now, in the lungs, okay, no? Siyempre, ang carbon dioxide dapat, it has to be exhaled out. Now, this carbonic acid, exhaled through the lungs, of course. The carbonic acid is very unstable. So, right away, no, it now splits into hydrogen and bicarbonate. Okay? So, H2CO3 is very unstable, so immediately it will split into hydrogen and bicarbonate, HCO3. Now, the hydrogen that is released will now cause the lowering of the blood pH. So, therefore, if you have an increased carbon dioxide in the blood pH goes down as a result of accumulation of hydrogen, no, when the carbonic acid degrades, no, into a hydrogen and bicarbonate. Okay? So, ganon ang storya nun, no? So, we usually define respiratory acidosis, no? Of course, we always look at the pH. Whenever the pH goes lower than 7.35, we define it as acidosis. Now, since there are two types of acidosis, one is respiratory and the other is metabolic, then you have to know the distinction. So the acidosis is respiratory when it is the PCO2 or carbonic acid that fluctuates. All right? So if the level of PCO2 or carbonic acid fluctuates, napabago-bago, pataas or pababa, then that means there is a problem in respiratory aspect of the acid-base balance. So tatawagin mo ngayon siyang respiratory. Okay? Respiratory acidosis if there is an increase, if there is a decrease in pH, no? And in that case, no, the PCO2 would increase. It is greater than 45 millimeter of mercury. Hindi siya mailabas ng baga. So the carbon dioxide is retained in the lungs. Alright? And because of that, sabi natin, CO2 plus water equals carbonic acid. And later on, carbonic acid splits into hydrogen. And so, the hydrogen contributes to the acidity. Okay? So, saan condition mo makikita yan? Of course, in many of the lung disorders, such as asthma, COPD, yan, makikita mo yan dyan, ano pa, and in some drugs, no? There are drugs that would also cause metabolic respiratory acidosis. Later, you will see them in the video. So, COPD, asthma, and even in stroke, kasi i-depress niya yung respiratory system sa brain. Okay, so therefore, the lungs would have difficulty of exhaling, no? Exhaling the carbon dioxide. So, the carbon dioxide is retained in the lungs, and so the carbon dioxide mixes with water, becoming carbonic acid, and carbonic acid immediately splits to hydrogen, all right, and into the bicarbonate, and that would now cause the respiratory acidosis. Okay, so that's the first aspect. Mamaya makikita nyo, no? Bigay ko muna yung discussion. And then in the respiratory alkalosis naman, so that's the opposite of respiratory acidosis. So here, the pH is higher than 7.45. And sabi natin, PCO2 at saka pH inversely proportional. So if pH increases, PCO2 decreases. So pH value of arterial blood more than 45 millimeter of mercury, that means alkalosis yun. And so we expect that, since it is respiratory, we expect that the carbonic acid or the PCO2 fluctuates. So, ang mangyayari naman dito, the PCO2 level goes down as a result of excessive exhalation. Lagi kang nagbubuntong hininga, lagi kang humihinga ng malalim, naglalabas ka ng maraming carbon dioxide. And because of that, there will be less carbon dioxide left in the lungs. So decrease PCO2, that would mean kokonti ang magiging carbonic acid. Kokonti ang mapoproduce na hydrogen. So we call that alkalosis. Okay? We call that excessive exhalation, excessive release of carbon dioxide. We call that hyperventilation. Okay? So, yung laging nagbubuntong hininga na parang pasan ang mundo, parang maraming problema, that may lead to respiratory alkalosis. Okay. Now, in either situation, respiratory acidosis and respiratory alkalosis, the body does something to correct the problem. Kasi obvious na may imbalance. Dapat 7.35 up to 7.45 lang ang blood pH. Pero sa dalawang examples, hindi na siya ganon ng value. And therefore, you now have a condition called imbalance of acid and base. Okay? So pag tumataas ang acid, that means carbonic acid or PCO2 yon, di ba? So that means you have acidosis. Okay? That means sumataas ang PCO2 mo, that means you have acidosis, tama, low pH, no? Alright, pag sinabi naman natin base, that's referring to the bicarbonate. And when the bicarbonate value changes, it follows that the blood pH would also change. So if the blood pH fluctuates from the value, the normal value, 7.35 to 7.45, we call that metabolic if it's the bicarbonate level that changes or that deviates from the normal. Diba ang normal value ng bicarbonate? 22 to 26 millimole per liter or 22 to 26 milliequivalent per liter. Now, do not be confused with the units. It may be expressed in millimole per liter or milliequivalent per liter. Parehas lang yan. Kasi ang bicarbonate, may valence siya na -1. So kapag ang valence ay 1, whether plus or minus, parehas lang ang value ng milliequivalent at millimole per liter. Do you understand? CC1 yan. Yan yung conversion factor, hindi ba? Basta ang valence ng electrolyte or ion ay 1, then therefore, millimole per liter and milliequivalent per liter is the same ang value. Okay? Now, if bicarbonate accumulates in large amount, bicarbonate is acid, is base. Alkaline yan di ba? So therefore, edi alkalosis siya. So if the concentration of bicarbonate exceeds the value, the normal value na 26 millimole per liter, therefore we call it metabolic alkalosis. And if the value of bicarbonate depresses, becomes lower than 22 millimole per liter, then we call it metabolic acidosis. Okay? Between the two, there are more recorded cases of metabolic acidosis. Kamukha, kunwari ng diabetes mellitus, ayan, metabolic acidosis yan. Okay? So, and you will see the other conditions after we watch the video. Now, whenever imbalance exists in the body between acid and base, the body has to do corrective action. Kailangan i-correct ang problema. Hindi yan po pwedeng pabayaan na ang blood pH fluctuates from the normal value. No? In order to maintain homeostasis or balance or to be healthy, so the blood pH, when it fluctuates, it has to be corrected immediately. So kung ang problema ay lungs, and therefore we call the imbalance respiratory, there must be a compensation mechanism to correct the problem. And the compensation, no, is the work of the kidneys. So kung ang may problema ay lungs, ang gagawa para i-correct uli ang value ng pH ay yung kidneys. Kung ang may problema ay kidneys, ang magko-correct ng problem ay ang lungs. So therefore, there are two organs that play vital role in the maintenance of acid-base balance. These two organs are the lungs for the respiratory and the kidney for the metabolic. When the respiratory aspect is in trouble, then the kidneys will do the correction. Siya yung mag-compensate. If the problem is in the kidney, metabolic nature, then the lungs will compensate. Okay? So, dun sa kaninang metabolic alkalosis, let's say you have taken the bicarbonate or antacid drug excessively. Let's say you are experiencing hyperacidity. So one way to correct that is you take antacid. Pag nangangasim ang sikmura, pag may GERD ka, or nangangasim ang sikmura mo, may hyperacidity ka, hindi ba ang gamot antacid? It will combat, it will counteract acidity. So ang gamot doon, isa doon ay bicarbonate. But let's say you have overdose of bicarbonate, nasobrahan ka ng inom, nakalimutan mong nakainom ka na pala, na doble ang dosage ngayon. So therefore now you are experiencing metabolic alkalosis. So how does the body correct the problem? Gagawin ng lungs, alright, so tumataas ang blood pH, ang gagawin ng lungs ay mag-hypoventilate. Okay? Hindi dapat mapapansin mo magiging slow ang respiration rate mo. Mabagal ang paghinga mo. Hindi malalim, no? Shallow, slow respiration. That is being done by the lungs so that the increasing pH would now be normalized. Mapababa ng konti. Kasi in hypoventilation, carbon dioxide accumulates in the lungs. And when there is carbon dioxide, it binds with water. And the binding produces carbonic acid, which immediately splits to hydrogen. Okay? Magre-release ka agad yun ng hydrogen. So that hydrogen now will neutralize the metabolic alkalosis or hyper pH, no? Hyper metabolic alkalosis ang problema. So gagawin niya ay pataasin ngayon ang hydrogen level so that bumaba ang blood pH. Okay? Now, what about in metabolic alkalosis? Okay, madami ka ng metabolic acidosis. So in metabolic acidosis, the pH is lower than the 7.35. So, ang gagawin ng lungs, okay, is mag-hyperventilate. So, mararamdaman mo, ayan, parang bumubuntong hininga, malalim ang paghinga mo. Okay, sobrang lalim, humuhugot ka ng carbon dioxide from the lungs and nilalabas mo excessively. Alright? So, in that way, the problem would now be corrected. Okay? Now, you will be given sets of values in a little while. And again, we'll try to work on the problem, on the given data, now in preparation for your quiz next meeting. Also, if we still have time, I can give you now your grades in the lecture because I already encoded some of the sections. So, tapos na akong mag-compute ng isang araw pa. Okay? So, kaya ko na ibigay ang grade nyo only for the lecture. Okay? Now, luckily, there were students who attended the class last Saturday and they got high score in in the CP work, which I added, the scores I added in your CP. Okay? So sige, are you now ready to watch the video? Now, I will be giving chance for the student leaders who missed the activity last Saturday. So at the end of this video, after watching the video, all right, I will be flashing some uh, sets of data now on the ABG test. So I will be showing you ABG test results, sample test results. And you need to define or identify the situation on whether it is uncompensated, compensated, or partially compensated, or fully compensated. Ano nga uli ang ating sinabi doon? Uncompensated if the pH is outside the normal value. And the two parameters, PCO2 and P and bicarbonate, one of them is normal and the other one is abnormal, uncompensated. Partially compensated when the pH is abnormal and the two other parameters are both abnormal. So in other words, the three parameters of ABG, all of them, they have abnormal test results. Kaya naman naging abnormal ang isa doon sa dalawa, PCO2 and bicarbonate, kasi nagko-compensate na, humahabol na. And usually the direction of the problem, ang compensation mo ay same ang direction. So kung mataas yung isa na isang parameter, ang compensation patataasin niya rin. Kung mababa ang isang abnormal parameter, ang compensation pabababain niya rin. Okay? So that's what I meant by the direction of compensation is similar to the direction of the problem. Okay? Now, when do you say that it's fully compensated? When the two parameters, PO2, PCO2, and bicarbonate are still abnormal, but the pH now becomes normal. So, nag-normalize na, which means that compensation is successful. Okay? So, are we now ready? What about thumbs up? No, to signify your eagerness now to watch the video. Tatawagin ko yung mga walang score doon sa practice mamaya. Okay? And we will have also the second part of presentation for lahat sa inyo after watching the video. Okay, let's now watch the video.
This condition and cause us to retain carbon dioxide. Well, let's think about this for a moment. Whenever you're breathing in oxygen and you're breathing out carbon dioxide. And you got to get rid of that carbon dioxide because if you don't, it's going to lower your blood pH. So any conditions that lower our breathing rate, where it causes us to breathe too slow, like bradypnea. And this is a respiratory rate less than 12 breaths per minute in an adult. Also, if we have damage to those gas exchange structures in our lungs, like those alveolar cells, where we're not having that proper exchange of oxygen and carbon dioxide, we can for sure retain too much carbon dioxide and drop our blood pH. In addition, if we have an issue with the muscles that aid in the respiratory rate. For instance, our diaphragm is too weak and we start getting into those neuromuscular disorders that will affect our ability to breathe. So to help us really understand this condition, let's go back and talk about carbon dioxide and gas exchange. So with respiratory acidosis, we have established that we have retained carbon dioxide levels. So what is carbon dioxide anyways? Well, carbon dioxide is a waste product that is created from cell metabolism. And your body needs this certain little range of it, about 35 to 45 millimeters of mercury. Too much of it is bad and too little of it is bad. So here in acidosis, we're talking about having a level greater than 45 because we're retaining way too much CO2. So your body must deal with this carbon dioxide. And what it does is it takes it, dumps it into the blood, and your blood will take it up through the heart to the lungs where gas exchange is going to occur. And it's really cool how gas exchanges in your body, because whenever you're breathing in, you're breathing in oxygen. That oxygen goes in through your nose, down into your lungs, and then it's going to cross over into these little alveoli sacs, and it's going to go into your blood. And your blood's going to take it, replenish all your organs with oxygen that it desperately needs. Now, that waste product that's built up in your blood, that carbon dioxide, it's going to cross over and it's going to go through the alveolar sac, but it's going to go up through your lungs and you're going to exhale it. And your respiratory rate can adjust itself. It can increase its rate or decrease its rate depending on how much CO2 it needs to get rid of. Now let's back up to whenever CO2 is being created from the cell metabolism. So it's created, it's that waste product. So your body takes it, dumps it into the blood. Now when CO2 enters the blood, it's going to find some water molecules and it's actually going to bind with water. So CO2 and H2O, they bind together. When they bind together, we get the creation of carbonic acid. Carbonic acid is a very weak acid. It doesn't stay together for too long. So whenever we get the formation of it, it actually breaks apart into like hydrogen ions and bicarb. And I want you to particularly pay attention to hydrogen ions. The hydrogen ions is the thing that really affects our blood pH, because whenever we measure blood pH, we're measuring the concentration of hydrogen ions. And hydrogen ions are acidic. So if you have too many hydrogen ions, that is going to drop your blood pH. And remember, a normal blood pH is 7.35 to 7.45. So it's extremely narrow. So whenever you have too many hydrogen ions hanging out in the body, it's going to make your blood pH less than 7.35. It dropped it. But if we don't have a lot of hydrogen ions, we are going to actually increase our blood pH. It's going to be greater than 7.45. But here in acidosis, we have way too many hydrogen ions on board, so we have a blood pH of less than 7.35. So you may be thinking, what's the big deal about carbon dioxide and hydrogen ions? Well, they're extremely related, because whenever we get carbon dioxide binding with water, we get the creation of that weak acid, carbonic acid. Since it's a weak acid, it breaks apart. Whenever it breaks apart, we get hydrogen ions. So if we have a lot of carbon dioxide in our body, let's say we have a patient who has a neuromuscular disease, they're not breathing very well, the respiratory rate is extremely slow, what are they retaining? A lot of carbon dioxide. So we have a lot of carbon dioxide hanging out in the blood. That means it's binding with water. When it binds with water, we get carbonic acid being formed, which is going to start giving us a lot of hydrogen ions in our blood. When we have a lot of hydrogen ions in our blood, that drops our blood pH and makes it acidic, which is why we have respiratory acidosis. So now let's look at some conditions that can lead us to retain carbon dioxide, because we've established that we have a depression in lung ventilation. Either we're breathing too slowly, there's damage to the gas exchange structures in our lungs, or our respiratory muscles are just too weak to help us exhale this carbon dioxide. So to remember those causes, let's remember the word depress. D is for drugs, such as opioids and sedatives. Those are really big ones. They depress your respiratory rate, cause your patient not to breathe very fast. So whenever you do give these medications, you've definitely got to monitor your patient's breathing rate. Also, diseases, this goes along with this D, diseases of the neuromuscular system, such as Guillain-Barré syndrome. With that, we start to get paralysis that will extend up to our respiratory system, which will cause your patient not to be able to use the respiratory muscles to breathe, which again will cause us to retain CO2. E is for edema, particularly pulmonary edema. This is where we have fluid in the lungs. Whenever you have fluid hanging out around those alveolar sacs, it's going to prevent proper gas exchange from occurring, which also happens with the P of our mnemonic, pneumonia. And then we have R for the respiratory center of the brain is damaged. This can occur in patients who have experienced a stroke. So your breathing rate is really controlled a lot in your brain. And if someone's had ischemia to particular parts of their brain that control the respiratory rate, it can affect how well they're able to ventilate. E is for emphysema. This is where the patient has overinflated alveoli sacs, so we're impairing gas exchange. S is for spasms of the bronchial tubes, like in asthma, again, impairing gas exchange. And then lastly is sac elasticity of alveolar sacs are damaged. And these are in patients who experience COPD. And in patients who have COPD, they are known as being CO2 retainers because we are not having that proper gas exchange in their sac. So one thing you want to remember about patients who have chronic COPD, meaning they've had this condition for a very long time, they are in this chronic state of acidosis because they retain CO2. And because they've been retaining the CO2 for a long time, their body has adjusted to this. So we have to be extremely careful with the amount of oxygen that we administer to these patients, which we're going to talk about in nursing interventions. Now let's talk about how you can know if your patient is experiencing respiratory acidosis. One big way is to look at those arterial blood gas values. So let's quickly go over that. So whenever we're talking about respiratory acidosis, the first thing you want to look at is that blood pH. A normal blood pH, as I said before, is 7.35 to 7.45. And again, that was the measurement of those hydrogen ion concentration in our blood. So we have a very acidic blood level. So what do you think that blood pH is going to be in respiratory acidosis? It's going to be less than 7.35. Then we want to look at that PaCO2 level. That is the amount of carbon dioxide in the arterial blood. A normal level is 35 to 45 millimeters of mercury. So with this condition, we have established that we are retaining carbon dioxide. So what is our level going to be in respiratory acidosis? It's going to be greater than 45 millimeters of mercury. And then another thing we want to look at is the bicarb. This is represented as HCO3. And a normal level is about 22 to 26 milliequivalents per liter. So in respiratory acidosis, you can have a normal bicarb level. If this was the case, that would mean that you have no compensation going on, so it would be uncompensated. Or if we had partial compensation going on, that bicarb level would be greater than 26, because a level that is greater than 26 on that high side is considered alkaline, and a level less than 22 is considered acidic. So if we have acidosis going on, our body's in an acid state. So to help compensate, our bicarb can come in because it is a base and it can help put itself on the alkaline side by reserving more bicarb, like our kidneys retaining more bicarb. So hopefully becoming more alkaline, this will help that pH to increase a little bit and get out of that acidic range. Therefore, with this bicarb, our kidneys can play a role with helping conserve some of that bicarb and excrete some of those hydrogen ions so we can get that pH normalized. Now let's look at the signs and symptoms of respiratory acidosis. So a big thing that you're going to see with these patients is that they are going to have some neurostatus changes, where before they may have been alert and oriented, but all of a sudden you're noticing that they're getting confused. They're not responding to you properly, or while you're actually talking to them, they're falling asleep, so they're getting drowsy, and they can report a headache. Plus, they're going to be hypoxic, where they have low oxygen in their blood. And that goes back to how we were talking about with the patho. Because of how they're breathing, let's say that their respiratory rate has slowed down, they're not taking in a lot of oxygen. Or if they have damage to their alveolar sacs, we're not having the gas exchange occurring properly, where the oxygen is crossing over into the blood. So we're dropping those oxygen levels. And because we're dropping our oxygen levels, our body is going to sense this. So it's going to increase that heart rate in hopes of trying to get more oxygen throughout our body because it desperately needs it. Plus, they can have a low blood pressure. Now, in clinical practice, whenever I've seen patients with respiratory acidosis, I have noticed the neuro changes and the hypoxia as one of the biggest signs that tip me off that we might have an acid-base imbalance. For example, I had a patient come back from surgery, and the patient before they left for surgery was alert, oriented, normal, and whenever they came back, I knew they were going to be a little bit drowsy, but as they were supposed to be coming off the sedation and recovering, they were starting to progressively get worse. They were getting confused, didn't really know where they were. In addition, while they were talking to me, they would just completely just nod off and fall asleep, and it was very just outwardly told me something was going wrong. And then whenever I had them on their O2 sat monitor, their oxygen was just plummeting downwards. So notified the doctor, got an arterial blood gas, And yes, the patient was in respiratory acidosis. So really pay attention to that neuro status and their oxygen status if they have an O2 monitor. Now let's talk about our role as a nurse where we're providing care to a patient with respiratory acidosis. So we've established that these patients are going to have a low oxygen level because we're retaining carbon dioxide, we have issues with ventilation, gas exchange. So the doctor may order us to administer oxygen. Now with this, you want to be really careful with what patients you're administering oxygen to and how much. So look at your patient's health history, because as we were talking about in our mnemonic, that last part where we're talking about patients who have COPD, whenever a patient has chronic COPD, they are in this chronic state of acidosis because they are retaining CO2. And their body has actually compensated for this and has become used to these high CO2 levels. So a low oxygen level actually guides their respiratory function. So you want to be really careful that you don't go too high with their oxygen levels because it could decrease their breathing rate. In addition, whenever we have a patient with respiratory acidosis, we want to make sure we are paying attention to their respiratory status. How are they breathing? What's their rate? And we want to look at their neuro status because, again, as I was talking about with signs and symptoms, that is one of the most subtle changes that I have seen whenever a patient starts to experience this condition. Plus, if your patient, let's say, has pneumonia or they have some type of issue going on with gas exchange, coughing and deep breathing, using that incentive spirometer can help improve gas exchange. So we want to educate the patient on this and how to do it. And if your patient has a lot of fluid in the lungs, suctioning could be helpful, along with providing mouth care, because studies have shown that the bacteria in our mouth, if it gets down into our lungs, it could lead to pneumonia. So we want to make sure that we're routinely cleaning that mouth from those secretions. And bronchodilators can be beneficial. So administering a breathing treatment can go in there, dilate those airways so we can improve gas exchange. And holding any medications that could decrease their respiratory rate. So if you have a patient with respiratory acidosis, go look at their medication history or what they're currently receiving and ask yourself, is there anything in this list that could be decreasing their breathing rate? We don't want to give that to them right now. And we want to make sure that we're monitoring their electrolytes, because whenever acidosis presents, it can affect potassium levels, because it will cause potassium to leave the inside of the cell and go to the outside of the cell, the extracellular compartment, which is our blood plasma, which could lead to hyperkalemia. And if we get hyperkalemia, this can affect our heart, causing dysrhythmia. So we want to make sure we're watching the ECG as well. And then lastly, if the patient's CO2 levels are getting really too high, they may...
Yes, have you heard that, no? About the correlation of potassium level with imbalance. Di ba? We also discussed that in the electrolyte part, right? Sabi natin, no, increased potassium is seen in respiratory acidosis. And this was validated in this video, okay? Increased level of potassium may cause respiratory acidosis. So as she was saying, these are some of the interventions. No, although sabi niyo, bakit nursing intervention? It's nice to know then, no, na ito pala yung mga pwede na mga interventions. Okay? Now, regarding the administration of oxygen to correct respiratory acidosis, sabi niya, no, there must be a close monitoring or regulation of oxygen or administration of oxygen. As I mentioned to you last time, sabi ko, delikado ang sobrang oxygen administrations, no? Kasi it may lead to the patient may go blind. Okay? Pag nasobrahan ng bigay ng ang oxygen, pwedeng makabulag yun. So, that's why the nurses should keep an eye on the oxygen being administered to patients who have chronic respiratory acidosis.
May need some help blowing off that carbon dioxide. So they may be intubated so they can get mechanical ventilation where we can actually decrease those CO2 levels. So you want to help get your patient prepped for that. Now let's focus on respiratory alkalosis. Respiratory alkalosis occurs in the body whenever we have increased lung ventilation. So whenever a patient is increasing their lung ventilation, unfortunately, this causes the CO2 level in your body, the carbon dioxide level, to drop down. But it causes the pH level to increase. So we now have an alkalotic state in the body. So one of the main causes.
So you see, no, the relationship of carbon dioxide to pH is inversely proportional. Ayan, obvious, no? Tandaan niyo yan, no? Low carbon dioxide, high pH. So this is the case of respiratory alkalosis. So yung sobrang nilalabas ang carbon dioxide through deep exhalation. Medyo hindi yan dapat observe, no? Masama that because it may lead to respiratory alkalosis.
Of respiratory alkalosis is actually called tachypnea. And tachypnea, tac means fast, is a really fast respiratory rate. Typically in adults, this is greater than 20 breaths per minute. So we don't want someone breathing that fast. So let's think about it for a second. You have this person, they are breathing extremely fast. What is coming out of their mouth? What are they exhaling whenever they're breathing really fast? They're exhaling carbon dioxide, CO2, and we don't want to get rid of too much of this. So here with respiratory alkalosis, we have already said that we have a low carbon dioxide level. So when you have a low carbon dioxide level, you don't have a lot of carbon dioxide binding with water. You're not getting the formation of a lot of carbonic acid, which is a weak acid, and therefore, whenever it breaks apart, you're not getting a lot of hydrogen ions. So we're dropping our hydrogen ions, which is increasing our blood pH. So do you see why whenever we have a low CO2 carbon dioxide level, we have a high blood pH? So we have alkalosis. And again, the main cause is tachypnea. So whenever the patient is breathing really fast, they're exhaling that CO2. So what are some conditions or things that could cause your patient to breathe really fast? Well, to help us remember those things, let's remember the word tachypnea. T is for temperature increase, fever. So whenever your patient has a really high fever, it can cause them to breathe really fast and blow off CO2, putting them in respiratory alkalosis. A is for aspirin toxicity, like salicylates. C for controlled ventilation.
Very important, no? So when a person therefore has high fever, so a person might now be suffering from respiratory alkalosis. Tandaan nyo, ha? So pag nilalagnat, respiratory alkalosis. So then, take note of this mnemonic. Maganda, no? Kasi madaling tandaan. Okay, so please take note. This is a very good learning material.
Is too excessive. So we have them on some type of mechanical ventilation. It's just way too fast for them and they're just blowing off too much CO2. H is for hyperventilation. Whenever patients get a lot of anxiety, if you've ever seen someone having a panic attack or severe anxiety, notice that they really breathe very fast. This can cause this. And then Y is for yelp. They have pain. Whenever a patient's in pain, it will affect their vital signs. Their heart rate can go up, their blood pressure can go up, along with their respiratory rate. Then P for pneumothorax. This is where we have a collapsed lung. So whenever you have a collapsed lung, that's definitely going to alter gas exchange and affect how well you can get rid of carbon dioxide. N is for neuro change. We're talking about our brain, like inflammation of the brain or brain injury. We know that there's centers in our brain that control our respiratory rate. So if those are inflamed or damaged, it can affect how the patient breathes, which could cause them to go into an alkalotic state. E is for embolism in the lungs, and then A is for ascending altitude. So whenever you go up in altitude, you have low oxygen. And whenever you have low oxygen, your body's like, hey, I need to breathe some more. So it might try to hyperventilate to try to take in more oxygen. Well, when you're hyperventilating, as we've already talked about, you're going to blow off too much CO2. Now let's talk about how a patient's arterial blood gases are going to look whenever.
Therefore, class, when you go up the mountain, when you're doing mountain climbing, you may experience respiratory alkalosis. Sobra ang hingal mo, kaya magre-respiratory alkalosis. Okay?
Whenever they're experiencing
Miss sandali Meron ako, pwede bang from time to time, titingnan nyo yung chat box? Meron akong minalalagay na note doon, no? Like, I'm calling the attention of Miss Carasido. Please respond.
alkalosis. How can you tell whenever you look at that blood gas that your patient has this condition? Well, you want to look at three specific things. One thing is the blood pH. Again, that pH is telling us the concentration of hydrogen ions in the blood. So a normal blood pH is 7.35 to 7.45. So whenever we're talking less than 7.35, we're talking about the blood being really acidic. So if it's really acidic, we got a lot of hydrogen ions in there. If it's greater than 7.45, we don't have a lot of hydrogen ions in there, so the blood is alkalotic. And that is the case with respiratory alkalosis. We're going to have a blood pH of greater than 7.45. Then we want to look at the PaCO2, which is the concentration of carbon dioxide in that arterial blood. A normal level is 35 to 45 millimeters of mercury. So with this PaCO2 level, anything that's less than 35 is going to be considered alkalotic. Anything greater than 45 is considered acidic. So here we don't have a lot of carbon dioxide, so it's going to be, you'll see results less than 35 millimeters of mercury, which is on the alkalotic side. Then you want to quickly look at the bicarb level, the HCO3. So this tells us if we got some compensation going on. This value can be normal or it could be abnormal. So a normal bicarb level is about 22 to 26 milliequivalents per liter. So anything with this bicarb when it's less than 22 is considered to be on the acidotic side, and anything greater than 26 is on the alkalotic side. So again, it could be normal. If it was normal and all those, the blood pH and the PaCO2 were abnormal, showing the values for what it should be for respiratory alkalosis, we would have respiratory alkalosis, no compensation, so it'd be uncompensated. But if this bicarb was less than 22, and we have the abnormal values for blood pH and the PaCO2, which is telling us respiratory alkalosis, and our bicarb is less than 22, we would have partial compensation because this bicarb is trying to make things a little bit more acidic for us. So we can bring that blood pH down, because right now it's too high. We need to bring it down. So with compensation, our body has a lot of systems in place to help balance these acids and bases so we can get our blood pH back into 7.35 to 7.45 range. And we have, the hydrogen ions, which are our acids, but we also have bases. And a big base in our body that our body likes to use is bicarb, the HCO3. So here in this case, we really have too much basic stuff going on. So we can get the kidneys involved, and the kidneys help tweak bicarb and hydrogen ions. So what the kidneys can do is that it can excrete the extra bicarb, because we don't need too much of that because we already have alkalosis, and it can start to retain hydrogen ions, which again are acidic. So if we're going to add hydrogen ions back into our blood, we can make it a little bit more acidic and hopefully decrease that blood pH, which is why you're going to start to see this.
Therefore, compensation for respiratory acidosis alkalosis may involve the kidney. It's either the kidney would retain bicarbonate or excrete bicarbonate, or retain the hydrogen or excrete the hydrogen from the kidney.
Bicarb levels start to decrease, get less than 22. Now let's talk about the signs and symptoms of respiratory alkalosis. So we just talked about how they're going to look on a sheet of paper with their blood gas results. But what are they going to be presenting with whenever you go in and you look at them? Well, one big sign and symptom you're going to see, of course, is an increased respiratory rate. You're also going to start to see neuro changes as it progresses to get worse. So you could start to see anxiety, especially if this is caused by a panic attack. You're going to start to see fear, dizziness, which could progress to seizures in severe cases. In addition, their heart rate can be elevated, and you particularly want to pay attention to this heart rate because they can start to experience ECG changes. And these ECG changes are going to come from electrolyte imbalances, which can be very serious. So two electrolyte imbalances I want you to remember that can occur with respiratory alkalosis. They are hypocalcemia and hypokalemia. So we're talking about a low calcium level in the blood and a low potassium level in the blood. So why is this occurring? Well, first let's talk about the low potassium level. So whenever a patient has a low carbon dioxide level in the blood, like in this condition, it causes potassium to move inside that cell, so intracellular, which drops our blood levels. Now with calcium, what happens is that whenever the blood pH becomes too alkalotic, it causes calcium to misbehave in a sense. It causes calcium to want to bind to albumin. And when it binds to albumin, it's no longer in our blood. It drops our blood level, so we'll have a low calcium level. Now, because of these electrolyte imbalances, it could cause not only the ECG changes, but your patient could start to have muscle cramping and tetany as well. So what is our role with respiratory alkalosis? What are our interventions and what treatments can we expect to be ordered? So with respiratory alkalosis, the big thing is that we want to find the cause and we want to fix that cause, because if the patient's having a fever, let's give them some antipyretics to decrease that fever. If they're having anxiety, let's help get them calm. Whatever it is, you want to find it and treat it. So the big thing is we want the patient to decrease the respiratory rate and rest, because if we can get them to slow that respiratory rate, it's going to decrease how much carbon dioxide they are putting out, expelling. So to help us remember our role, we're going to remember the word rest. R is for rebreather mask or paper bag. So just helping them slow down their respiratory rate is going to slow down how much carbon dioxide they're going to be putting out. So these are very simple things that we can do to help possibly correct that imbalance. E is for electrolytes monitored, particularly, again, what were those two big electrolytes? They were potassium and calcium. S is for sedatives or anti-anxiety medications to be administered. This is just going to help calm them down, which when we calm them down, they're going to decrease their breathing and again, quit hyperventilating. And then T is for teach relaxation and de-stressing techniques. So the big thing, if you have a patient who goes into respiratory alkalosis because of stress, anxiety, a big thing is teaching them prevention. What are some things that they can do to prevent this from happening, avoiding certain situations? And then whenever the attack comes on, what they can do to help decrease that breathing and decrease the stress associated with it. Now let's break down metabolic acidosis. Metabolic acidosis occurs whenever we have too many acids in the body. And this leads our blood pH to fall along with our bicarb level, which is the HCO3 level. Now, this tends to occur really due to two reasons. The first reason being there is just too much acid production in the body. Some process in the body is messed up and we have way too many acids hanging out there. Or secondly, there is failure of our body to actually excrete or rid itself of these acids. So what are some things that can do this? Well, to help us remember those things, let's remember the word acids. So A is for accumulation of lactate, which leads to lactic acidosis, and this happens in cases of sepsis. C is for chronic diarrhea, where the patient is just losing too much bicarb through their stool. So bicarb is this like basic substance. It helps neutralize acids. And if we're losing a lot of this substance that helps neutralize acids, we're losing the ability to keep those acids in control, which could lead to acidosis. I is for impaired renal function. So your kidneys play a huge role in helping you balance those acids in your body. It can help get rid of those hydrogen ions. So if we have kidneys that aren't working very well, we're going to start to have high amounts of waste, hence acids in the body, which leads us to acidosis. And then D for DKA, which stands for diabetic ketoacidosis. So already in that name, you see acidosis. So we're dealing with something that's acidic. And with this condition, we have an increase of ketone production, which is acidic and causes our blood pH to fall. And then lastly, we have for S, salicylate toxicity. So these are acidic substances. So if a patient has too much of these in their system, it could cause acidosis. Now to help us understand metabolic acidosis a little bit better, let's take a moment and talk about acids. So your body metabolizes substance to function. This process is going to break down fats, carbs, and proteins, and it's going to take energy energy from that and give it to us. Now, unfortunately, a byproduct of this process is the creation of acids. So what are acids? Well, these are materials that once broken down in a solution, they create hydrogen ions. And this is what a pH level measures, the hydrogen ion concentration. And our body needs a narrow pH range in order to function. It needs a range between 7.35 to 7.45. Anything less than 7.35 is too acidic, and anything greater than 7.45 is too alkaline. So hydrogen ions play a huge role in affecting our pH level. It actually decreases the level and makes the body acidic. So if you have too many hydrogen ions in the body, that is going to lower our blood pH and make it less than 7.35. If you don't have a lot of hydrogen ions in the body, it's going to raise that blood pH and make it greater than 7.45, making it too alkaline. Now our body knows that this can happen, so it has these systems in place to help balance this out. The body wants a 20-to-1 ratio of bases versus acids. So for every 20 bases you have, it wants 1 acid. So it can keep the acid base.
Class, very important, ha? Memorize the ratio of acid to the base. So 20 bicarbonate for every 1 carbonic acid. 20 bicarbonate for every 1 carbonic acid. Or kung babaligtarin mo, 1:20, 1 carbonic acid for every 20 bicarbonate. Must to memorize ratio. Tinatanong ito sa board exam. Okay? Importante yan.
Balance. So the body uses systems to remove and neutralize these acids. And what really neutralizes an acid? A base. So bases neutralize acids. And the body can use the respiratory and the renal system to help remove or conserve them. Now, how do we get the creation of hydrogen ions in the body? Well, it's through carbonic acid. Carbonic acid is a weak acid in the body that plays a role in acid-base balance. It comes from carbon dioxide, and it's formed when carbon dioxide binds with water in the body. So when you breathe in and you take in carbon dioxide, it enters your blood, it's going to bind with that water. Whenever those two bind together, it forms carbonic acid. Now, carbonic acid is weak. It doesn't stay together too long. It actually breaks apart and creates hydrogen ions. And hydrogen ions can neutralize bases. So now let's take a deeper look into the respiratory and renal system that helps us balance these acids and bases. With the respiratory system, it will control the carbon dioxide levels. Either it will cause us to retain CO2 or blow off CO2. So it will control the rate of how fast we breathe and how deep we breathe. With acidosis, one of the big things you're going to see with these patients, because their body's trying to compensate for this, is that they're going to have fast, deep breathing, known as Kussmaul breathing. And why their body is doing this is because it's trying to blow off all that carbon dioxide. Now, why does your body want to blow off carbon dioxide? Well, what we just discussed is whenever carbon dioxide enters the body, it hits the blood, binds with water, we get the formation of carbonic acid. Carbonic acid is a weak acid, it breaks apart, and it's going to affect our hydrogen ions. Too many hydrogen ions in the body lowers that blood pH. So if we can get rid of that extra carbon dioxide through breathing, we can alter carbonic acid, which is going to alter hydrogen ion concentration. So in hopes, we're going to increase that blood pH to normal. Now, the respiratory system usually does this within minutes, so it's a pretty fast acting system. However, the renal system, I like to refer to it as the slow and steady system. Once it takes over, it does a pretty good job of helping us balance the acid and bases, but it can take up to days. So what our renal system can do is that it can mess with the bicarb levels, the HCO3. So we've learned that HCO3 bicarb, it's basic, it neutralizes acid. So if we're hanging out in some acidotic conditions like with metabolic acidosis, we need us some bicarb. So the kidneys, they know this. So what they can try to do is they can start to retain bicarb, which will help neutralize those acids. We neutralize acids, we increase blood pH back up. Plus, the kidneys, specifically those nephrons within the kidneys, can start tweaking the hydrogen ion concentration. So we can start excreting extra hydrogen ions. Now, how are a patient's arterial blood gas results going to look whenever they're in metabolic acidosis? Because ABGs is one of the great ways we can tell if a patient is in this type of acid-base imbalance. So whenever you look at those ABGs, you're going to look at three things. You're going to look at the blood pH. Again, what was a normal? 7.35 to 7.45. So with acidosis, it's going to be less than 7.35. Next, you want to look at that bicarb level, the HCO3. A normal level is 22 to 26 milliequivalents per liter. With acidosis, because we're talking about metabolic acidosis, HCO3, that's telling us we're dealing with a metabolic disorder, it's going to be less than 22 on the acidic side. And then the PaCO2, which represents our respiratory system, a normal level of that is 35 to 45 millimeters of mercury. With acidosis, it could be normal, so it could be within that normal range. But if the respiratory system is trying to compensate, like how we just talked about a moment ago, that level will be less than 35 because it's telling us it's trying to lower those carbon dioxide levels. So if it was that and our blood pH was still abnormal, it would be partially compensating. So we just seen what some ABG results can look like on a patient in metabolic acidosis. But how's the patient going to look whenever you're in their room assessing them? Well, number one, we established that their breathing rate is going to be abnormal. They're going to have that cough-small breathing where it's fast and deep. And why are they doing that? To breathe off that CO2. Also, neurally, they're going to be confused. They can be weak. Their blood pressure can be affected. Another big thing is you want to look at their ECG. You want to make sure that their T waves aren't abnormal because they can present with hyperkalemia. Acidosis leads to this. Now, why is this? Well, whenever a patient has severe acidosis, it causes the potassium inside the cell intracellularly to move outside the cell extracellularly, which is going to elevate those levels. Now, what are some nursing interventions for the patient that you want to remember? Well, one thing you want to remember is that with metabolic acidosis, they need to find the cause and treat it. And there's a lot of causes that can lead to metabolic acidosis when we talked about our pneumonic acid. So the treatments will vary depending on the cause. Therefore, as a nurse, one thing you really got to keep an eye on is the patient's electrolyte levels. So one level you want to pay attention to is that potassium level, which is what we just talked about. So you're looking for hyperkalemia. But here is the thing about it. Once this acidosis starts resolving, especially in a patient who has diabetic ketoacidosis, what can happen is that you're going to have a problem with hypokalemia. So now we're going to be dealing with a low potassium level. And why is that? Well, a lot of times with DKA, one of the interventions you're going to be doing per the doctor's orders is you're going to be administering IV fluids and insulin. So whenever we give insulin, what insulin does is that it will cause potassium to actually move inside that cell. When we move it out of the blood inside the cell, we can cause hypokalemia. So you want to monitor for that. You also want to make sure that you're monitoring the patient's neurostatus and that you're ensuring their safety. And some IV fluids that could be given. Again, this varies depending on why your patient's in metabolic acidosis, but some fluids could include sodium bicarb or normal saline. And if this is being caused by renal failure, the patient can go for dialysis, which will, in a sense, act as the kidneys and filter out the blood and help increase our blood pH back to normal. Now let's take a look at metabolic alkalosis. Metabolic alkalosis results in an elevated blood pH and an elevated bicarbonate level, HCO3. And this usually occurs because we've had excessive loss of acids such as hydrogen ions, or we've had an increase in the amount of bases like bicarbonate, that HCO3. Now, what are some conditions that could cause either of these two things to happen? Well, to help us remember those conditions, let's remember the word alkali. Alkali is a synonym for base. First, we have A for acid loss via the stomach. Your stomach acid is really rich in hydrogen ions. So if we are over suctioning the patient, removing too much of their GI juices, or they're vomiting, they're losing a lot of hydrogen ions, which when we drop hydrogen ion concentration, we increase that blood pH, because all blood pH is measuring the concentration of hydrogen ions in the body. Then we have L for low chloride level. When we have a low chloride level in the body, this causes our kidneys to start to decrease its excretion of bicarbonate. So when we decrease excreting bicarbonate in our urine, that's actually going to raise the levels in our body. When we have too much bases, they are going to neutralize those acids, which will will throw us into these alkalotic conditions. And then we have K for potassium loss. So whenever we have hypokalemia in a patient, what happens is that it really affects hydrogen ions. It causes those hydrogen ions to move inside the cell. So instead of being in the fluid surrounding that cell, in that extracellular fluid, it will start to migrate inward, which will drop our hydrogen ion amounts, which is going to increase our blood pH. Then we have A for aldosterone increase. So whenever we have a condition like hyperaldosteronism, we have a high level of aldosterone in the body, it's going to do three things. One thing is it's going to cause our body to keep sodium, which in the end is going to cause us to waste more hydrogen ions. Again, we're losing our hydrogen ions, which raises our blood pH, and keep bicarb. And then we have L for loop and thiazide diuretics. These diuretics, they increase urinary output, but also in that urine will be potassium. So we're at risk for hypokalemia. And whenever we put a patient in hypokalemia, we just learned it messes with the hydrogen ion concentration, which will increase the risk of developing metabolic alkalosis. And then lastly, I for infusing too much sodium bicarb IV. So this could happen if the patient was in, let's say, metabolic acidosis, where they were ordered sodium bicarbonate. They received too much, so now we flipped them over into alkalosis. Because bicarb in that sodium bicarb fluid acts as a base. So if we give them too much of a base, that will go in there, neutralize too many hydrogen ions, which we don't want, and send them into alkalosis. Now, to help us understand metabolic alkalosis a little bit better, let's talk more in depth about bases. Bases are materials that once you break them down in a solution, they neutralize acids by binding with the hydrogen ions. So in a sense, what it does is it acquires a hydrogen ion and then neutralizes it. And an important base in the body is called bicarbonate, HCO3. And this is actually a weak base that will help neutralize, hence bind to acids like hydrogen ions. And when they do this, they increase the pH level. Now, your body has these internal systems that help maintain this acid-base balance. The two systems I want to talk about are the respiratory and renal system. With the respiratory system, it works fairly fast whenever we have an acid-base imbalance. And how it works is that it affects carbon dioxide levels by causing you to change your respiratory rate and depth. For example, your respiratory system can cause you to breathe faster and deeper. And whenever you're doing that, think about what's happening. What are you blowing off if you're breathing really fast and deep? You're blowing off carbon dioxide. And this is really beneficial whenever you are experiencing acidosis. On the flip side, your respiratory system can cause you to breathe slower. So think about it. Whenever you're breathing slower, what are you keeping more of? You're keeping more of carbon dioxide. And this is very beneficial whenever you have alkalosis going on, where you're too basic, because keeping carbon dioxide is going to cause you to create more hydrogen ions. So a lot of times whenever you have a patient in an alkalotic state, you will see that they have bradypnea, where their respirations are slow. They're having hypoventilation. And the whole purpose of this is to keep that carbon dioxide, because when we keep the carbon dioxide, that stays in our blood. That carbon dioxide is going to bind with water. When it binds with water, it's going to form carbonic acid. Carbonic acid is a weak acid, and it breaks apart. When it breaks apart, it increases hydrogen ions. Those hydrogen ions will go in there and neutralize the bicarbonate. Whenever we neutralize the bicarbonate, that is going to help bring down that blood pH to normal. And then the renal system will come into play. Now, I like to think of the renal system as the slow and steady system. It's like the turtle. It's slow, but once it gets going, it does its thing. So with this system, what's going to happen is it is going to help retain hydrogen ions. So why do we need hydrogen ions? Because they're going to help make things more acidic, which is really needed when we have metabolic alkalosis. So those hydrogen ions will go and neutralize that bicarbonate. Plus, the kidneys can start to excrete extra bicarb, which again will help lower that blood pH. Now, one of the ways you can tell that your patient's in metabolic alkalosis is that you can look at their arterial blood gas results, their ABGs. So what are ABGs going to look like in a person with metabolic alkalosis? Well, there's three things you got to look at. You got to look at the blood pH, the bicarbonate level, and the PaCO2. So the blood pH, again, a normal was what? 7.35 to 7.45. With this, the blood pH is going to be greater than 7.45. It's going to be on the alkaline side. The bicarbonate, which represents our metabolic system, a normal is 22 to 26 milliequivalents per liter. And with this, it's going to be elevated. So it's going to be greater than 26. It's going to be on the alkaline side. And then our PaCO2, which represents our respiratory system, it can be one of two things. It could be normal or it could be elevated. So a normal level is 35 to 45 millimeters of mercury. If the body isn't trying to compensate, that respiratory, the PaCO2, is going to be normal because our body hasn't decreased our respiration yet in hope of retaining that CO2. So it'll just be within that 35 to 45 range. However, if it was trying to compensate, like partially compensate, it would start to cause your respiratory system to keep that CO2. So you would start to see the CO2 levels rise and they would be greater than 45. Now that we know what a patient's arterial blood gases will look like with metabolic alkalosis, how will they be presenting with their signs and symptoms? A big one you're going to see is bradypnea. That's those slow respirations. Now that's a compensatory mechanism, but it can become really severe where it leads to respiratory failure. And the patient can have dysrhythmia. So you really want to pay attention to their ECG because this is arising from hypokalemia where we have a low potassium level. So whenever a patient has a low potassium level, you want to look specifically at that ST segment. With a low potassium level, it will be depressed. And you'll want to look at their T wave, which could be inverted, like flipped upside down. Now, normally after the T wave is a flat line, but whenever you have hypokalemia where it's severe, you can actually have what's called a U wave after that T wave. Also arising from this low potassium level could be tetany, tremors, muscle cramping. They can feel tired and irritable. What are some nursing interventions for the patient with metabolic alkalosis? Well, of course, we want to monitor that ECG, the respiratory status, and neurostatus. We also want to keep an eye on their electrolyte levels, particularly potassium due to hypokalemia, and that chloride level, which could be hypochloremia. So the healthcare provider may order supplementation that you will be administering to the patient. And if the patient is vomiting, we want to address that because remember, those GI juices are really rich in hydrogen ions, and we need to keep those hydrogen ions in this condition. So an antiemetic may be ordered. Also, certain diuretics may need to be held, particularly those loop and thiazide diuretics. And the reason for that is because they drop our potassium level. And when we drop our potassium level way too low, it affects hydrogen ion concentration, making alkalosis worse. And sometimes a medication can be ordered called acetazolamide, which brand name is Diamox. And this is a carbonic anhydrase inhibitor, and it's actually a diuretic. And what it does is it decreases the reabsorption of bicarb, so we're not keeping more bicarb. Instead, it's going to help us excrete it via the urine, which is really helpful when we're in alkalosis. Now let's talk about the ABG sample collection process by reviewing the modified Allen test. The modified Allen test is performed before collecting an arterial blood gas on the radial artery. Now, what is an arterial blood gas? This is also sometimes referred to as an ABG, and it's a blood test that's collected from an artery that assesses the oxygenation and acid-base balance of a patient. And the blood sample for this test can be obtained through an arterial line, also known as an ART line. And think of this as like direct access to a patient's radial artery. A lot of patients who are in the ICU have an arterial line, or it can be obtained through a needle stick via an artery. The most common artery used for this type of test typically is the radial artery, but the femoral and the brachial artery can be used as well. Now, why do we do a modified Allen test before we collect an arterial blood gas sample from the radial artery? Well, let's talk about the radial artery for a moment. So find your thumb. Located just below your thumb, over where your radial bone would be, is your radial artery, and you can feel it pulsating. And then just next door, on the other side where your ulnar bone is located, that's your ulnar artery. Now, these two arteries work together to deliver fresh oxygenated blood to your hand and its structures. And we always want to make sure that these arteries can do that. So this modified Allen test is going to check blood flow to the hand to ensure there is good collateral blood flow to the hand in case that radial artery develops problems after the ABG collection. So in other words, it wants to make sure that your ulnar artery can work as backup in case we need it. So now let me demonstrate how to perform the modified Allen test. Before you perform the modified Allen test, you want to turn the patient's hand so the palm is facing up, have the patient make a clenched fist, and then find the radial and ulnar artery. And to help you remember the steps of this test, remember the word Allen. First, you're going to apply firm pressure to the radial and ulnar artery at the same time with your thumbs or fingertips. This will temporarily stop blood flow to the hand. Then let the patient open and close their hand several times. The hand will start to lose its color, hence it's going to appear lighter or blanched. Loosen pressure on the ulnar artery only, but keep pressure on the radial artery. Then evaluate the return of blood flow from the ulnar artery to the hand. A normal response will be that the hand returns to normal color, hence appears flush within less than 5 seconds. And if this is the case, you know that this radial artery is good to go for collecting an arterial blood gas. Now that we've reviewed that material, let's focus on solving arterial blood gas problems. You can solve these problems in many ways, but first I'm going to demonstrate the tic-tac-toe method. The tic-tac-toe method is a method you can use to solve arterial blood gases, and it's very similar to the childhood game that you may have played as a kid, where you set up the little grid lines and you use X's and O's and you're trying to get that 3 in a row. It has the same concept, except we're not using X's and O's, we're using arterial blood gas values like PaCO2, bicarbonate, pH, and we're not just getting any type of 3 in a row. We have to get a vertical 3 in a row. So I'm talking about a 3 in a row that goes up and down. So first, let's look at an overview of how this method is set up. So whenever I go to solve these problems, because I want to be solving uncompensated ones, partial and full compensation, you'll have a little bit of an idea as I'm setting up this problem. So here is a completed one. I want you to look at the grids. Notice how we set up the grids just how you would in a childhood tic-tac-toe, and we've labeled each like column. So you have acid over there all the way to the left, then you have normal in the middle, and then you have base all the way at the right. Then we've plugged in our arterial blood gas results, so we've had to interpret them. So we've plugged in the PaCO2, that represents the respiratory system. We figured out that that was normal, so we put it under the normal column. Then we looked at the pH, and it is basic, so we put that under the basic column. And then the HCO3 was basic, which represents the metabolic system, and we put it under the basic side. So now we're looking at the tic-tac-toe, we're looking for that 3 in a row, and we're looking for a vertical 3 in a row. So we got one right here with base, pH, and HCO3. So how do we interpret what it is? Well, you say base, which is another way of saying base is alkalotic. It's alkalotic, and the pH is alkalotic, and the HCO3 is considered alkalotic. So when we put all that together, we get metabolic alkalosis, and this problem is uncompensated, which we'll be going over that here in a second. So that is how you set up the problem. Now, before you even go working these problems, you have to first have a basic understanding of how to interpret ABG results. So let's quickly go over that. First thing, whenever you're looking at ABG results, you need to look at the patient's blood pH. This is like the measure of the hydrogen ion concentration.
You'll always start from
your body likes a narrow range. 7.35 to 7.45 is the range that's considered normal. So anything less than 7.35 is considered acidotic, an acid, and anything greater than 7.45 is considered basic, which another way of saying basic is alkalotic. Those are like synonyms, you can interchange those. Then next you want to look at the PaCO2. This is the carbon dioxide level concentration in the arterial blood. Whenever we're talking about PaCO2, that always represents the respiratory system, so remember that. So a normal level is about 35 to 45 millimeters of mercury. So when you're looking at these results, anything that's less than 35 is considered alkalotic, basic, and anything that is greater than 45 is considered acidotic, and acid. Then you want to look at the bicarb, which is HCO3. This always represents the metabolic system. So HCO3, metabolic, PaCO2 is respiratory. So a normal bicarb level is anywhere between 22 to 26 of milliequivalents per liter. So anything that is less than 22 is an acid, and anything greater than 26 is a base. Now, whenever you're looking at these lab results and you're thinking, how am I going to memorize this? Try to keep these few things in mind. One thing is about that respiratory system. It's a little bit special when it comes to its values. It's the opposite on whether it's an acid or a base compared to pH and the bicarb, because notice with pH and bicarb, its low values like 7.35 or 22 are automatically considered an acid. But when we go over here and look at PaCO2, its low value, that 35, it's considered a base. So notice it's opposite. Always remember that or you'll get confused. In addition, remember 35 to 45, because if you can remember that number, you've knocked out two of the values. For instance, 7.35 to 7.45 is a normal pH. See the 35 and the 45? And then remember for PaCO2 respiratory, it's 35 to 45. That's its normal. So if you remember those two numbers, you've just memorized two values. So now let me test you. Okay, you have a blood pH of 7.52. What is that? It is a base, so it's alkalotic. In your tic-tac-toe, you put it on the base side. How about a PaCO2 of 32? That is a base. It's considered alkalotic. How about a bicarb HCO3 of 28? It's considered basic, alkalotic. Okay, how about a pH of 7.31? That is acidic. We put it on the acid side. And how about the pH was 7.36? That's normal. So you put under the normal side. So these next problems we're going to solve are actually from my book I just released on ABG interpretation. And in this book, I include a lot of practice problems to make sure you know how to solve all these different types of ABG problems, along with cheat sheet style notes to help you remember those important concepts about acid-base imbalances and so forth. So now that we have that out of the way, let's set up our first tic-tac-toe problem. Okay. Patient's ABG results are pH of...
Okay, let's start. Sino ang mga walang recitation? Those who failed to take the sit work, yung ating class activity last time, you please answer. The rest you can also answer. Okay, you can also answer. But of priority are those who were absent. Okay? Okay, time starts now. Pwede bang teka muna, I will call the name ha. I will call the name. Wait. Dali. Dali lang ha. Gahete, nandyan? Miss Gahete?
Yes po din.
Okay, isa ka ha. And then, number 14. Mijares, are you there?
Yes po.
Mijares. Ramos, are you there? Wala ka din.
Yes po din.
Okay, and then the last is number 4. Halinganga, andito?
Yes po din.
Okay, kayo munang apat. Kayo munang apat ang sasagot. Okay, write your answer on the chat box. Hurry. Answer now, please. Okay, respiratory acidosis si Halinganga. Okay, next. Isa pa lang sumasagot. Apat kayo. What about the others? Wait, wala pa akong tanong kung compensated or uncompensated. Sagot muna. The other two. Okay, next. Apat kayo. Who else have not answered? Okay, finish? All right, so Miss Ramos, please explain why you answered respiratory acidosis. Miss Ramos, why respiratory acidosis?
Kasi po, 'di ba, 'di ba po, 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 'di ba
Miss Bernardes, why respiratory acidosis? Kahete?
Ma'am,
Sino yan?
Bernardes po.
Uh, can you please again state your name?
Bernardes po.
Go ahead, Miss Bernardes.
Based po sa video po na we've watched, um, respiratory acidosis po yung answer ko. Kasi po yung value po na given sa situation po is fall under the
Okay.
acid.
Okay. The first step is to look at the pH. Yan ang unang step, Ham. You look at the pH. Miss Bernardes, what can you say? Normal, abnormally high, abnormally low?
The pH po is abnormally low po.
Okay, therefore you answered acidosis.
Yes.
Okay, that's correct. What about you, Miss Ramos? What can you say about the partial pressure of carbon dioxide? Low, normal, high? Ramos, low, normal, high, partial pressure of carbon dioxide. Wala ba si Miss Ramos? Gahete. What can you say about the partial pressure of carbon dioxide?
Ang partial pressure po ay acidic po.
High, low, normal.
Low po.
Bakit low? Di ba what's the normal value of partial pressure of carbon dioxide? Tingnan nyo nga, ano ba ang normal value ng partial pressure of carbon dioxide? Hindi ba 35 millimeter of mercury up to 45 millimeter of mercury? Why did you answer low? Why did you answer low? Miss Napo? Napo, are you there? Napo? Wala. I'm checking the attendance now as I call your name, ha? Sabihin kahit nakaregister kayo dito, kapag hindi kayo sumagot, absent kayo. Just raising your hand. Sino yan? Go. Sige, sagot. Marion. Sige, Paule, sumagot ka. What is your answer, Mr. Paule?
For PaCO2 level po din, it is abnormally high po since the normal
Yes.
is 35 to 45 po. And the
Okay.
value is 50 po.
Okay. So what was your answer, Mr. Paule? Ano sagot mo? Metabolic acidosis ba? Metabolic alkalosis, respiratory acidosis, respiratory alkalosis?
Respiratory acidosis po.
Your answer is the same as the others, respiratory acidosis. Okay? So the pH is low and the PCO2 is abnormally high. Okay? And bicarbonate, what can you say, Mr. Paule? Low, high, normal?
As for the bicarbonate din, it is normal po since it
Okay.
is 24.
Okay, so everything, okay, qualifies under what? So sabi natin, kapag uncompensated, pH is abnormal. The other two parameters, one is normal and the other is abnormal. That's uncompensated. Magiging partial compensated when the pH is abnormal and the two other parameters, CO2 and bicarbonate, are also abnormal. That's partially compensated. And it's fully compensated when the pH goes back to normal and the two other parameters are still abnormal. Kasi na-correct na nung isa doon. Okay? So, now the next question is, so the answer in this given case is, anong tawag dito? This is acidosis because the pH is lower than 7.35. And the nature of acidosis is respiratory because it is the carbon dioxide that level that is fluctuating. In this case, we call it respiratory acidosis. And it conforms with the requirement para maging acidosis. Sabi, If the carbon dioxide is more than 45, then we call it acidosis. So the answer in the first case given here is respiratory acidosis. So all the four got the correct answer, including Mr. Paule. All right? Now, the next question, still yung lima na yun ang sasagot. What kind of compensatory mechanism? Pakisulat niya sa chat box. Isulat niyo sa chat box ng mabilis. Hurry up. Okay? Last na call. Sulat sa chat box kung anong klase ito. Okay, stop answering now. Stop answering. No more, please. Now, the answer is, Miss Austria, what was your answer, Miss Austria? Go ahead, Miss Austria. Marian. Marian. Ano ba yan? Hindi kayo sumasagot. Kahete.
Uncompensated po siya din dahil yung bicarbonate level po niya ay normal. Whereas yung dalawa pong yung pH po at yung kanyang PaCO2 po ay abnormal.
Okay, so what is now your complete answer, Miss Calhete?
Respiratory acidosis uncompensated po.
Uunahin mo anak yung uncompensated. So your
Okay
answer
po.
must be
Uncompensated respiratory acidosis po.
acidosis. Okay? So that's now the answer. Tingnan natin ha. Tingnan natin kung yun nga isasagot niya.
7.25, a PaCO2 of 50, and a bicarb HCO3 of 24. So the very first thing you want to do is that you want to set up the problem. So go ahead, put out your lines, and then label each column. We have acid all the way over there on the left, we have normal in the middle, and then we have base here on the right. So the first thing what you want to do is you want to interpret those results. Let's start with the blood pH. The pH is 7.25. That is acidic. So we're going to write pH under the acid column. Then we're going to look at the PaCO2. It was 50. That is considered an acid. So we're going to put PaCO2 under acid. And I'm seeing something. I'm seeing some vertical activity going on. But let's finish out the problem. And then we're going to look at the bicarb, the HCO3. It is 24. So that is normal. So we're going to put our bicarb under normal. So again, just remember, PaCO2 represented the respiratory system, and the bicarb, the HCO3, represented the metabolic system. So now what we're going to do is we're asking ourselves, do we see a vertical 3 in a row? And the answer is yes, we do. So we can actually finish solving this. So what we have is we're going to say acid plus pH plus PaCO2. What do we get when we do that? We're going to get respiratory acidosis, and it's uncompensated. So we don't have any compensation going on. How would we know if we had any, where it would be partial compensation instead of uncompensated? Well, our HCO3, which is the system that's not the imbalance, should be trying to help us correct the
Question, how can respiratory acidosis, even in this case, be compensated by the kidney? How can this be compensated by the kidney, knowing that we have a problem in the lungs, and the lungs accumulates large amount of carbon dioxide, maybe because of asthma, COPD, emphysema. So how can the lungs compensate or correct the problem? Go ahead, Sophia.
Din, clarify ko lang po, ang tanong niyo po is how does the kidney compensate? Po, sorry po, medyo mainit po.
Yes, that's
okay, so
correct.
the kidney can compensate po by retaining the bicarbonate ions po. Bali,
Okay.
mag-iwas na siya increase po ng reabsorption.
Okay, so one mechanism is for the kidney to retain the bicarbonate. Because bicarbonate is something alkaline. Mengano, what's another way to compensate?
By releasing hydrogen ions po by the kidney.
Okay, very good. Another possible way is for the kidney to allow excretion of excessive hydrogen. In that way, no, maybe the 7.25 will now begin to rise slowly. So, kung ganyan, therefore, kung bicarbonate will be retained, dapat tumaas yung 24. In order to correct the problem, the value of bicarbonate would soon start rising by retaining it, no, by the kidney. So patataasin ng bicarbonate. So 24 yan, no, dapat tumaas pa yan ng konti dyan. The normal value is 22 to 26. Siguro maybe it can go as high as 28 para makorek ang problem. So when bicarbonate rises because na-retain sa kidney, let's say naging 28 millimole per liter siya, therefore the pH will start to rise. So let's say you have a value na 28 millimole per liter for bicarbonate, mataas na siya than normal, and the pH now would also start rising up. So yung sinasabi ko kanina na ito kung tataas ang bicarbonate, remember, ang problema sa carbonic acid mo, ay sa CO2 mo, high. Therefore, ang compensation mo ay pataasin ng bicarbonate. Kaya yun ang sinasabi ko kanina, kung ano yung problema, yun din ang direksyon ng compensation. So the problem, you have a very high carbonic acid, so the compensation is to increase also the level of bicarbonate.
These acidotic conditions by becoming more alkaline. So that bicarb, the HCO3, should be going up, being greater than 26 if it was partial compensated and our pH was still abnormal. So that would be partial compensation. But right now our bicarb is normal. So it's not trying to make itself more alkalotic. So it's staying within that normal range, so it's uncompensated. But let's say that whenever we did this tic-tac-toe, we didn't have a vertical 3 in a row, because that sometimes happens. And when that happens, it automatically tips you off. You have full compensation.
Okay, ito yung sinasabi ko kanina. When all the values seem to be abnormal, that means partial compensation. However, when two parameters, carbon dioxide and bicarbonate, are still abnormal, and only the pH is normal, then that is full compensation.
Which I'm going to go more into detail about that when we solve those problems. Plus, if it was full compensation, our pH would have been normal. So if you don't get a vertical 3 in a row and your pH is normal, you can know that you do have full compensation. So with this problem, it says our patient has the following ABGs: a pH of 7.2.
Okay. Now, let's have this next set of problem. Now, I'll be calling the following students. Medyo marami-rami ito. Ay, ito pala. Wait, numbers at 13. Munyar, are you there? Munyar?
Yes po.
Okay, sasagot ka ha. Then number 3, Breeze, are you there?
Yes po, Dean.
And then number 5, Paule. Kasi Paule, sumagot ka na kanina, ano? Okay.
Yes po, Dean.
Pa naman ang sasagot dito. Let's have number 2, Bernardes, are you there? Bernardes. At saka number 14, Parungaw. Oh, sige. Bernardes, Parungaw. Okay, sige. Please answer now this one. Nakakatatlo pa lang si Ana. Okay. Go, sagutin niya yan. The others also please join in answering. But I'd like to give priority for those who don't have the support. Go, start answering now. So what kind of imbalance is this or abnormality?
6, a
Go, please write your answer in the chat box. Hurry up. Time starts now. 1. Hanggang 5 lang ha. 1, 2, 3. Isa pa lang ang sumasagot. 4, 5. Tapos na? Okay? Maybe we can now stop. Okay? Stop na tayo. Tama na muna dito, no? Okay. Si Gonzalez says respiratory acidosis. Gubalia says metabolic acidosis. And then, tignan natin si Viado, no? Tama ba? Kanino ba tayo nagsimula dito? Baka magkamali akong pag-ano dito. Kanino nagsimula ang tanong? Kay Paredes? Just Breeze? Yes, go ahead, Breeze.
Yes po.
Sa'yo nagsimula?
Opo.
O sige, kay Breeze nagsimula. Okay. Breeze, go ahead. Why did you say metabolic acidosis? Anong unang step, Breeze?
First is to look at the pH po, which has a
Okay.
value of 7.26.
So, what is
Abnormally
that?
low po siya.
Abnormally low. Therefore, ano yon?
It is acidic po or acidosis.
Okay, good. Next step, Breeze.
Then the given po is PaCO2 na 31,
What
which
is
is
that?
abnormally low naman din po siya.
Low ang PCO2 mo, okay?
And then which indicates it's a base po. And then the last po is the bicarbonate, which has a value of 20, which is abnormally, which is acid naman po.
Sabihin mo muna kung high, low. Huwag nyo kaagad i-interpret ng acid, gano'n. Malilito kayo. Ulit.
Yes.
Ulit. Ang unang step, you look at the pH. Sabihin mo muna kung normal, high, low. Sige, what can you say about 7.26?
pH is abnormally low.
Low. And then what can you say about PCO2?
PCO2 is abnormally low also.
Okay, the value should be 35 to 45. So this is low. Okay, next. What about the bicarbonate? What can you say? Normal value?
And
22 to 26. So what can you say?
the bicarbonate is also abnormally low.
Okay, so what kind of imbalance is this, Mr. Brice? What
This
is
is
Oto's
considered
answer?
acidosis po, specifically
Correct.
metabolic acidosis.
Sige, acidosis ka, no? Because less than 7.35. Okay. What kind of acidosis is this, Carcido?
Ma'am, ano po pala? Respiratory acidosis.
Ikaw, respiratory ka, Miss Carcido. Carcido, respiratory acidosis ang sagot mo. Pero si ang sagot niya ay metabolic acidosis. Paredes also answered metabolic acidosis. And the rest, metabolic acidosis. Si Gonzales, respiratory acidosis. So dalawa kayong respiratory acidosis, no? Ms. Garcido, why did you say respiratory acidosis, Garcido?
Kasi po, pag respiratory acidosis, yung pH po mababa. Tapos yung PaCO2 po, base siya. Tapos yung yung HCO3 po, normal. Para po yung kanina.
HCO3 ba normal? Hindi. Hindi normal.
Ano pala, acidic pala po.
Okay, so tingnan natin ha. Let's ask Munyar. Munyar, justify your answer. Miss
Hello
Munyar.
po, ma'am.
Yes, go ahead. Tama ang acidosis Tama ang acidosis. All of you got the correct answer with regard to acidosis. What about the nature of acidosis? Metabolic or metabolic?
It is
Go ahead.
It is metabolic acidosis po because of the bicarbonate deficiency, which is the value of 20 po.
Alright. Ang rule dito, kung saan medyo mas, yes, Ms. Garcido?
Pag-realize ko po pala, pag metabolic acidosis po, masyadong maraming acid po, sabi kanina.
Okay, so let's wait for let's see what the girl will tell us.
PaCO2 of 31 and an HCO3 of 20. So very first thing what we want to do is we want to set up that tic-tac-toe. So set up our problems, label each column acid, normal, and base. Then what we want to do is we want to interpret that blood pH. Is it acidic, normal, or basic, alkalotic? So our blood pH was 7.26. That is on the acidic side. So we're going to put pH under acid. Then we're going to look at the PaCO2. It was 31. That is on the base side. So we're going to put that under base. And then we're going to look at the bicarb, the HCO3.
Sino
And
ba
it
yung
was
sumagot kanina na nalilito dito? Tandaan nyo ang pH at PCO2 inversely proportional. So if the pH is low, therefore, ang PCO2 mo dapat mataas yun. Kaya ayan, no, magkabaligtad sila. The pH and the PCO2, they are opposite. Magkabaligtad yan. Pag tumataas ang PCO2 mo, acidic yon. Pag mababa PCO2 mo, base yon. Kaya ito alkaline dahil mababa ang PCO2. Normal value 35, 31 lang siya. So therefore, alkaline yung side na yon.
20. And when we interpret that, that is going to go under acid. So we're going to put that there. Now we're going to look for
22 to 26, so less than 20, edi acid. So now you have here acidosis. Okay, now what kind
a
of
vertical
acidosis?
3 in a row. Do we see one? We do.
Ayan.
We have one over here on the acid side. Acid plus pH plus bicarb. Again, what did HCO3 represented? It represented metabolic. So when we put all of that together, we get metabolic acidosis.
Metabolic acidosis. Okay, sasabihin mo, ma, bakit po naging metabolic? Kasi titignan mo kung alin ang mas, okay, although this one, no, pagka hindi ka gumamit ng tic-tac-toe na, na technique, no, sasabihin mo, alin dyan ang mas malayo sa normal, okay? Bicarbonate, 22 to 26. So may dalawa kang fluctuation dyan, di ba? Ang iyong PaCO2 dito ay 35. Kung tutuusin, pwede mo tong sabihin na respiratory acidosis kasi mas maano ang problem mo dito. Mas lamang ang problem mo dito. Okay? But here we see na everything here are abnormal. Ito yung mahirap i-answeran na case study no? Kasi pwede mo sabihin respiratory, pwede ko sabihin dito na respiratory acidosis because the PCO2 is lower than 31, no? Kaya lang magko-contradict sa value yon, di ba? Sabi natin, ang pH ay opposite ng PCO2. So nagko-contradict sila dyan. But, so what is aligned is more on the bicarbonate. Kasi when the bicarbonate is low, then you have acidosis. And if it is bicarbonate that is changing, then we call it metabolic. All right? Now, the next question is, what kind of compensation here is being shown? Or is there no compensation at all? So please type your answer. So mas makukuha mo kung magtitiktoe tayo dito. Kasi pwedeng sagot mo dyan pwedeng sasabihin mo, nagbabago ang PCO2, you may answer respiratory. Okay? Now, what kind of compensation here?
So now,
will you please answer again? Garcido, Paredes, Munyar, pakisagot, Gobalia. Yes, Garcido. Sulat yung sagot nyo. Uncompensated, fully compensated, or partially compensated? Write your answer. Write your answer. All right. Okay. What is the answer here? pH abnormal, PCO2 abnormal, then the bicarbonate abnormal. So it must be partially compensated. Let's see kung parehas
we
na
need to
sasabihin
determine what kind of compensation we got going on. So we know this is not full compensation because as I started out before,
not full
we
compensation.
do have a vertical
Because the
3 in a
pH is
row.
abnormal.
Plus, our pH is abnormal. Our pH would have to be normal for it to be full compensation. So we'll go ahead and forget about that one. So it's either uncompensated or partial compensated. So we need to further look at the system that isn't causing our imbalance. Our system that is.
Pag sinagot mo kasi to na respiratory acidosis, hindi ba sabi natin the relationship of pH to the CO2 inversely related. So if pH is low, dapat ang iyong, kung acidosis siya, edi dapat ang PCO2 mo mataas. Kaso here you see ang PCO2 mo less than normal, na dapat 35 ito. Therefore, hindi ito ang susundin mo. hindi siya consistent, in other words, no? That means it's more playing the role of compensation rather than this is the problem. But when you look at the bicarbonate, siya yung naka-align sa definition. Kasi, no, you have low than below 7.35 acidic yun, at ang bicarbonate mo ay low than 22. Therefore, siya yung acidic pa din. Okay, so therefore, mas masusunod yung metabolic side. Okay?
Is causing the imbalance is the metabolic system. So we know we have metabolic acidosis. So let's look over at that respiratory system value, and it's represented by the PaCO2. When we look at that, we put it under the base side. So it is abnormal. So the respiratory system is trying to compensate by making itself more alkalotic in hopes of bringing that pH to
Okay.
normal.
So the
So we
answer is
have metabolic
partially
acidosis,
compensated
partially
metabolic
compensated.
acidosis.
In our next problem, the patient has a
Kailangan ko muna tingnan yung mga score. Baka malito na ako. Wait. Rakin, wait. Miss Rakin, hindi ka sumagot dun sa unang anong klase, no? Compensation lang, Paul. Wait lang ha. Maglilista lang ako. Baka makalimutan ko. Malito-lito ako. And then, wait lang po. Pag ready kayo sa susunod na problem, Paule Kalamigan. Pero yung iba ha, pagka nakakuha na kayo ng score doon sa nakaraan, hindi ko siya dito na ilalagay ha, kasi na-compute ko na yung inyo eh. Iniintay ko na lang itong hindi pa nag-ano eh. And then mag-long. Actually, nag-start na rin ako mag-code sa encode ng section E. And wait, compensated. Magalang Vengano. Alright. And then Lena. Okay. And who else? Who else? Nessa. Alright. Carcido. Okay. Martes. Alright. Munar Kahete. Okay. The answer is, ano nga ba sagot nito sinabi? Ano nga ulit? Teka, nakalimutan. Ano sinabi nga ano sinabi natin na sagot? Respiratory, ay hindi, metabolic, di ba? So, mali si Barrow. Okay. Alipin si Gonzales. Respiratory, dapat metabolic. Wait lang. So, Munar, yes, correct. And then Paredes, correct. And then who else? Carcido, correct. Okay, well, who else? Okay, now we go to the next set of problem. Okay, that's na. So those who did not take the sit work last time, lahat nung galing sa EFGA, sige, last na to, sa inyo na to, your chance to have additional score. Let's go to the next one.
the pH of 7.54.
Bago na to, no, class? Bago na to, no?
Yes po.
Yes po.
Sagot na kayo, sagot na kayo. Sagot na kayo. Then you now should answer whether compensated, uncompensated, partially compensated, fully compensated, metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Buo na dapat ang sagot. Go, start now. Okay, what was your answer? Sige nga, pakinggan ko nga. Si Garcido, iba naman. Villa Flores, would you like to answer? Villa Flores.
Yes
Go.
po, ma'am.
Go, what's your answer? Kasi pa your
Ah,
answer. Ito.
uncompensated respiratory alkalosis po.
Okay, isayin natin. What can you say about the pH?
Yung pH po is high,
Okay.
which means alkalosis
CO2?
po.
Yung CO2?
PaCO2 po is low, and
Okay.
normal po yung HCO3.
Okay, normal. Okay. Therefore, yan kaagad ay uncompensated. Tama, di ba, no? So,
Po.
uncompensated what?
Respiratory alkalosis po.
Respiratory alkalosis. Okay. Nagtatali ba? Di ba sabi natin, when pH increases, carbon dioxide decreases. So, nagtatali sa definition. Okay? Tingnan natin, ha?
A PaCO2 of 27 and a bicarb of 23. So first thing we do is we set up our tic-tac-toe grid with the acid, normal, and base. Now let's interpret that pH. The pH is 7.54. What is that? Acid, base, or normal? Our pH is basic, alkalotic, so we're going to put that under base. Now let's look at the PaCO2. It is 27. That is basic, alkalotic, so we're going to put that under base. And then our bicarb HCO3, it is 23. So a normal one for that was 22 to 26. So we're going to put that under normal. Okay, next thing, we've interpreted everything. Now we need to see, do we have a vertical 3 in a row? The answer is yes, we do. It's on that base side. So when we take base plus pH plus PaCO2, again represent the respiratory system, we get respiratory alkalosis. So now we need to determine what kind of compensation we have going on. We can go ahead, throw out full compensation because we do have a vertical 3 in a row and our blood pH is abnormal. So is this uncompensated or partial compensated? So let's look at that system's value that isn't causing our problem. The problem is being caused by the respiratory system. So let's look at the metabolic system's representation, which was by the bicarb.
How can this be corrected? Anyone? How do you compensate for this? Yes. CP, go ahead.
Para po ma-compensate po yung respiratory alkalosis, ang ginagawa po ng kidney, nire-retain niya po yung hydrogen and ini-excrete niya po yung bicarbonate po.
Okay, so the kidney must reabsorb or retain the hydrogen to neutralize the alkalotic nature of the pH, or the bicarbonate be released excessively in the urine. Okay? To correct the problem. Kanino ako magsisimulang mag-check dito? Sino ako simulang sumagot? Kaninong pangalan? Nalilito na ako dito sa ano. Uy, sumagot kayo.
Ma'am, yung boat na po ba nasagot?
Oo, yung kompleto na, yung buo na. Sino unang sumagot? Sino unang sumagot na buo na?
Ma'am, si Miss Kalamigan po yung una.
Teka lang ha. Ayan, nalilito na ako sa pagda-document. Alamidan, bakit uncompensated? Hindi yung si Breeze, hindi si Breeze. Si
Kanina
Alamidan.
po yung kay Breeze.
Kanina yung kay Breeze. Nasaan si Alamidan? Ba't di ko makita? Nasaan siya?
Ma'am, Kalamigan po.
Ay, Kalamigan?
Yes po, ma'am.
Kalamigan. Wait. Nako, wow. Kalamigan, Lena, Peria. Tapos na to, no? Gubala, Villa Flores, Torres. Wala naman eh. Okay, Venus. Sige, pabalik ako. Ano nga sagot? Uncompensated. Ano nga sagot natin? Respiratory alkalosis. So, si Venus. Okay, next. Alosig. Uncompensated respiratory alkalosis, and then si Torres. Torres tuloy. Wait lang. Torres nga ba yung? Yes, Torres. Who else? Garcido, sumagot ka uli dito. All right.
Yes.
All right, wait. Villa Flores. Villa Flores. And then Paredes. Villa Flores, Paredes, Francisco, Palispis. Tingnan nyo, baka may mamiss ako class ha. Palispis. Palispis Ramos. Who else? Jas Reyes. Ba't di ko pa nakikita yung pangalan niya? Yes, Gubalia.
Ma'am, sorry po. Gubalya po. Nag-recite din po.
Wait, Reyes, Palispis Reyes. Wala na. Nalilito na ako. Hindi ko makita yung ano eh. Yes, Biado.
Visado din po, ma'am.
Okay. Si Tiamson. Renz? Sumagot ka dito, Renz? Sumagot ka dito. Tama yung sagot mo?
Yes po. Uncompensated respiratory alkalosis.
Napo also uncompensated. Karingal. Oh my goodness, ang hirap niya hanapin. Magalaw. Karingal. Bengano. Paulir, sumagot ka uli. Karingal.
Opo, Dean.
Pauling. Okay, nalilito na ako dito sa mga nakasulat kasi ang haba-haba na. Okay, class. I think you are now armed with the information that you need for your quiz next meeting. Tama? May tanong pa ba kayo? Okay na, no? Napaglinawan na tayo. So, gamitin natin tong ano na to. Very good tong strategy na to na tic-tac-toe. Alright? So, be ready for a long exam next meeting. Okay? May tanong po ba kayo? May tanong ba? Oh, yes. Espejo.
Din, tanong ka lang po kung matutuloy pa pong sagutan namin yung nasa canvas po.
Oo, talagang sagutan nyo. Sagutan nyo yun. Kasi ano yan, sagutan nyo na lang siya, no? That would be also considered. Pero for the midterm na yan. Okay? That will be for the midterm. Okay, maybe you can now use the rest of the time answering the pre-task doon sa inyong canvas habang magre-record. Lalilito ako dito sa mga nakasulat dito. Baka magkamali ako ng class. Since this is just a parang consideration, all right? If ever hindi ko malista tong lahat, no? I mean, this is just plus on your part dun sa mga hindi lang nakasagot last time. Kasi tapos na akong mag-compute dun sa iba. Hindi ko na yan pwedeng galawin. Naka-encode na nga ako dun sa ibang section eh. I'm just giving some consideration dun sa mga officers na excuse dahil nandun sila sa activity. Okay? Yes, Shannon, why are you raising your hand?
Ma'am, Ambre tsaka Gonzales din po nag-recite.
Ano sinagot mo, Miss Ambre? Ambre Shannon?
Yung uncompensated respiratory alkalosis po.
Okay, Hannah? Do you have concern, Hannah?
Din, gano'n din po kay Miss Ambre. Nag-chatbox din po ako.
Okay, sige. Okay. Sige, you use the rest of the time answering the pangalan ito, yung ating nakalagay na work ninyo. Alright. Now, nakalagay doon ang cut-off yata noon. Anong oras ko ba sinabi? 11:59 ba? Pero pwede ba up to 4 o'clock lang? So, up to 4 p.m., hindi ko na i-consider ang sagot ninyo. Alright? So you go back to the announcement, to the assignment part of the Canvas and answer the seat work there. I will only check your answer up to 4 p.m. only. If you go beyond that, wala ka ng score. Okay? You understand? Okay, Ashley, okay, you may now go to the assignment part and answer. Ashley, may tanong ka pa, anak? May tanong ka pa?
Good afternoon po din. Regarding po dun sa quiz po last time, nag-take na po kami ni
Yeah,
Miss
ipapakita
Castro
ko
po.
na ipapel. Nakita ko na sa...
Tapos nag-chat box din po ako. Thank you po.
Anong sagot mo doon, Ashley? Ano apelido mo,
Yung
Ashley?
talosig po, yung uncompensated respiratory alkalosis po.
Ito, na-record ko na iha. Na-record ko
Thank
na.
you po.
Okay, so sige, use the rest of the time answering. Okay na. Total, ano naman na nakapag-discuss na tayo dito. And I think you are all ready to answer, no? Your exam. O magre-ready kayo. Siguro mape-perfect yun na yung ano nyo next meeting ha. The quiz for next meeting would be on simula sa iron. Ano pa ba yun? Iron, acid-base balance, at saka yung anion gap. Naintindihan? Okay ba? Okay? Marion, what's your concern, Iho?
Dean, question lang po, if okay lang po bang
Paule to, no?
mag-source?
Marion Paule?
Apo, Marian Paule po.
Oh, yes, go ahead.
Magtatanong lang po ako if pwede po kaming mag-source out ng answers from other references po bukod sa PowerPoint para po dun sa action po doon sa may assignment po due ng 4 p.m.
Siyempre naman, pwede kayong kumuha kahit saan doon. Okay?
Okay po.
Kahit hindi lang sa PowerPoint, pwede kayong kumuha kahit saan. Madali, anyway, basta hanggang 4 o'clock.
Okay
But
po. Thank you po.
I will be using my PowerPoint for the discussion. At least meron na kayong hawak na PowerPoint. Okay? Up to 4 p.m. lang yan. Sige, sagutan nyo na mga anak. Go. Bye-bye. Thank you for attending the class.